Good afternoon, everyone. I believe we'll kick off this webinar on the implementation and findings from the Childhood Obesity Research Demonstration Project, focusing on the school setting. Thank you so much for joining us today. Next slide. My name is Carrie Doima. I'll be your moderator today, and I'm pleased to introduce our other speakers who represent three of the four Childhood Obesity Research Demonstration sites located in Texas, Dr. Deanna Helsher, located in Massachusetts, Dr. Becky Frankel, and located in San Diego, California, Helena Hoyt. Next slide, please. Before I provide a brief overview of the CORD project and kind of an introduction to the webinar, I just encourage people to place your questions in the chat box. We will have a question and answer session once all the presenters are done. Again, my name is Carrie Doima. I'm a behavioral scientist here at the Centers for Disease Control and Prevention, and we're delighted to have you join us. I represent a team in the Division of Nutrition, Physical Activity, and Obesity who, along with the grantees, were part of this project. Next slide. So before we get started, I just wanted to tell you and provide a little bit more background about the CORD project. The CORD project, as I said, was housed in CDC's Division of Nutrition, Physical Activity, and Obesity. You can see on the slide there, our task is to support all Americans across the lifespan with nutrition and physical activity, including building a healthy start, growing up healthy and strong, maintaining good nutrition, and staying active. You can see the star there, how this webinar fits into and the CORD project fits into our overall portfolio of really helping children get off to a good start and maintain that start through the school age, and also working on the management of children who have obesity. Next slide. So we all know the statistics, so I won't spend much time on those, but really thinking about our school-age children, about 17% of them have obesity, including about 5.6% with severe obesity. So this represents an important public health problem. We know that obesity tracks into adulthood, and it impacts the mental and physical health of children and adults. It also has consequences for our nation, including 1 in 4 young adults being unfit to serve in the military. And it is very costly. You see the estimate there in billions of dollars per year of medical costs. Next slide. So there are recommendations for childhood obesity, both a treatment, prevention, and treatment, and those really were the foundation of the CORD project, including the National Academy of Medicine or the Institute of Medicine recommendation on interventions and actions in multiple settings where children live, learn, and play, and the recommendations we have for the prevention and treatment of childhood obesity from the American Academy of Pediatrics and the United States Preventive Services Task Force, to screen children 6 years of age and older and provide or refer intensive lifestyle modification programs to those in need. Next slide. So CORD 1 really did build the foundation of our work, and it was authorized in the last reauthorization of the Children's Health Insurance Program in 2009. In the reauthorization, it required that grantees take a multi-sectoral approach to childhood obesity. And it focused on reducing obesity by improving the behaviors such as physical activity, increasing fruits and vegetables, and helping children and families choose healthier beverages, ensuring adequate sleep, and decreasing screen time and the consumption of sugary drinks and energy-dense foods. The target audience for CORD was low-income children aged 2 to 12 years of age, and really focused on these key settings of ECE, or the child care setting, schools, community, and healthcare. But the most important part of this slide is the 4 grantees. So we had 3 demonstration grantees located at the University of Texas, San Diego State University, the Massachusetts Department of Health, and then our evaluation grantee at the University of Houston. Next slide. So this is just a nice graphic representation of kind of the CORD approach, where you have in the different colors all of the different settings that impact children on the left side, so school, community, childcare, and then really trying to affect both the policy systems and environments of these settings, and then also supporting students and their families with education and social support. So a two-pronged approach. Working on improving the settings where children are, and working on improving the skills, education, and knowledge of those children and families. Next slide. So as I said before, CORD was unique in that it incorporated activities for the prevention and treatment of childhood obesity. And this really required a collective approach. So grantees used those community coalitions and really focused on those community clinical linkages within their sites. They tapped into key organizations who implement evidence-based practices, and this webinar is focusing on the school setting. Interventions in schools are important because they can prevent childhood obesity, and they can also improve the behaviors of children and the environments of the nutrition and physical environments, activity environments of schools. Sustainability and quality improvement were also on the grantees' mind, and they were able to embed this by using evidence-based approaches such as CATCH, SPARK, Planet Health, and Eat Well, Play Hard, which you'll hear about in the webinar. And also really providing this in-depth training and technical assistance to those key staff located in schools, supporting champions and teachers to really work towards behavior change with their target behaviors. Next slide. If you'd like to know more about CORD, as far as the overall CORD project or some of the publications that have come out, you can visit our website. It has all 22 publications out, and the project also, among many things, developed some toolkits that are also available for dissemination. So without further ado, I'll introduce the next speaker, and they can really go into the details of their project, and we can learn from them about the interventions in each of the CORD settings.
Okay, can everyone hear me? I'll take that as a yes. My name is Becky Frankel, and as Carrie said, I'm a research fellow at the Harvard T.H. Chan School of Public Health. So I just want to say thank you for this opportunity to share some of the details of the MA CORD school intervention. Next. So I'll just start by saying that the MA CORD project was a comprehensive, systematic intervention to prevent and reduce childhood obesity among low-income children ages 2 to 12 years. So I've noted some of our manuscripts at the bottom here where we previously described the overall design and evaluation of MA CORD. Next. So while this webinar is focused on our work in the school sector, I do want to mention that MA CORD overall used a multi-sectoral approach and was implemented across 6 community sectors or settings. So those were schools, health centers, after-school programs, community, early care and education, and WIC. Next. Okay, so in addition to system-level intervention targets, MA CORD focused on 5 individual and family-level behaviors that are evidence-based and potentially actionable. So these are our 5 behaviors. The first was replacement of nutrient-poor foods with fruits and vegetables. The second was decreased consumption of sugar-sweetened beverages. The third is increased physical activity. The fourth was decreased screen time. And the fifth was increased sleep duration and improved sleep quality. Next. So we implemented MA Cord in 2 diverse low-income communities in Massachusetts over the course of 2 school years. So we started in fall of 2012 and concluded in spring of 2014. We also selected 9 control communities for comparison using Euclidean distance matching based on racial ethnic composition and % low income in each school district. So the 2 intervention communities were predominantly non-Hispanic white with large Hispanic populations and had per capita incomes that were substantially lower than the state overall. About 2/3 of the student body in both intervention communities was defined as low income. And each intervention community had a single school district. So across the 2 communities, there were a total of 28 schools eligible to participate in the project. Next. So here are some more specific details about our intervention. The school sector intervention consisted of several main components. So the first was evidence-based health education curricula. We used Eat Well and Keep Moving for grades 4 and 5, and Planet Health for grades 6 and 7. Teachers were encouraged to incorporate 6 suggested lessons from Eat Well and Keep Moving and 5 from Planet Health that were specifically related to the target behaviors. The second component was teacher training and resources on the curricula. So in year 1, teachers received a 3-hour training that introduced curriculum materials to be integrated across major subjects, for example, math, language arts, and social studies. In one community, teachers were trained during school hours and MA Cord funds were used to compensate substitute teachers for that time. And then in the other community, teachers were trained after school and also compensated for their time. The third component was school wellness champions and district coordinators. So wellness champions, for example, school nurses and teachers, were identified at baseline in each school, and they led school-wide wellness activities, things like improved policies, fun runs, the media competition, that were really designed to reinforce MA Cord messages and classroom interventions. And then each district also used 1 part-time paid coordinator to oversee administration of MA Cord. Then the other components, of course, were the media competition that we had for students, and also the provision of physical activity supplies like balls and jump ropes. And I also want to note the after-school components as well. So we utilized professional development for staff and used the OSNAP and food and fun curricula there. So I've listed the websites at the bottom if you want to find out more about any of those curricula. Next. So the primary outcome of interest was obesity prevalence. And for our evaluation design, specific to obesity prevalence, we used a quasi-experimental design with pre-post data for the intervention communities as well as the 9 matched control communities. So here in Massachusetts, public schools are required to measure height and weight of all 1st, 4th, and 7th graders annually. And as a result, we had obesity prevalence data available to us for the 2 intervention communities as well as the 9 control communities for an extended pre-baseline period, so 4 school years preceding the intervention, for the 2-year intervention period itself, and then 1 year post-intervention as well. Next. And we had a host of secondary outcomes specific to the behavioral outcomes that I previously noted. Our evaluation design for these was a little bit different. We used a quasi-experimental design with pre-post data, but for the intervention communities only. Unfortunately, student health behaviors were not assessed in the control communities due to logistical constraints. But in the 2 intervention communities, at the time of height and weight measurement, during the 2012 to 2013 baseline year, and then again post-intervention during the 2014 to 2015 year, all 4th and 7th graders were invited to complete a written self-reported student survey that measured demographic characteristics, including age, gender, and race ethnicity, as well as the 5 target behaviors. Next. So just to say a little bit more about the survey, this is an example question. We asked about the dietary behaviors, and here was the question asking about vegetables. Yesterday, did you eat any vegetables? We specified what we meant by that, and then gave 4 responses, ranging from no, I didn't eat any yesterday, up to yes, I ate vegetables 3 or more times yesterday. And then, of course, we had questions about the other dietary behaviors, as well as physical activity, screen time, and sleep duration. Next. Next, there we go. So our primary analysis, like I mentioned, examined change in the prevalence of obesity in the intervention communities compared to change in the matched control. So these are the results. And I'll focus your attention on the text in the red box, where you can see that we observed a statistically significant decrease in the percent of students with obesity from baseline to post-intervention, specifically for 7th graders in Community 2 compared to the control communities. And we also observed a marginally significant decrease for 7th graders in Community 1. So these results translate to about a 2 to 3% reduction in obesity prevalence per year. And I do want to take a minute here to explain that the fact that we saw significant results only among 7th graders is actually consistent with how we implemented and evaluated the school sector intervention. Because of the fact that we were utilizing repeated population cross-sections of obesity prevalence for those 1st, 4th, and 7th graders in Massachusetts, at the time of post-intervention follow-up, only those students in 7th grade had actually received any of the classroom-based lessons. So for example, they were in 5th grade during year 1 of the intervention, in 6th grade during year 2, and then in 7th grade where we captured them at the post-intervention time point. So in other words, 7th graders were the student group with the greatest intervention exposure. Next slide. So here we have data on our behavioral outcomes. So to assess change in behavioral targets, the prevalence of target behaviors at baseline and post-intervention follow-up was examined. We used log binomial regression to estimate the risk ratio of meeting these behavioral targets, and we adjusted for any differences in student gender, grade, and race ethnicity between the pre and post-intervention periods. So using those adjusted models, we found that 4th and 7th grade students in both communities were more likely to meet the targets for sugar-sweetened beverages as well as water. And students in Community 2 were more likely to meet the target for screen time. So I'll just note briefly that overall, there were suggested lessons from both of the curricula, but they were related to only 4 of the 5 target behaviors. So unfortunately, since none of those lessons address sleep, the lack of effect on sleep duration is perhaps unsurprising. Next slide. So overall, MA Cord had several strengths, notably the large and racially ethnically diverse sample, in addition to our use of matched controls for the primary obesity prevalence analysis. In summary, we observed a decline in obesity prevalence among 7th grade students in one of the 2 intervention communities compared to controls, and this is consistent with how the school sector intervention was implemented and evaluated. We also observed improvements in selected behavioral targets, specifically sugar-sweetened beverage intake, water intake, and screen time. And given the brief duration of intervention, as well as the financial constraints of the 2 communities, these improvements are notable changes. I also just want to mention that in addition to our main student outcomes paper, we have also published a more detailed mixed method study that examined barriers and facilitators of implementation in the school sector. I didn't have time to go into those details today, but I thought this audience might find those useful. So I've included the citations at the bottom of the slide, and I'd be happy to answer any questions. Thank you.
Thanks, Becky. This is Deanna Helsher, and I'm going to present on the Texas Cord School Primary Prevention Process and Outcomes. So first of all, I'd like to acknowledge my other investigators down at the bottom of the slide, as well as the many partners that we had in doing this, and then our funding. So the Texas Cord study design, we incorporated both primary prevention and secondary prevention. So I'm not going to talk about, I'm just going to focus on the school segment today. But when you look at this, primary prevention is our, the reason we did primary prevention was to actually reach all of the kids in the community. So here in Texas, we were in both Austin and Houston, and in both of those places, we had 1 control and 1 intervention site, catchment area. So we had a total of 2 intervention catchment areas and 2 comparison catchment areas. As part of our primary prevention in those catchment areas, we targeted the elementary schools, the child care centers, we targeted primary care clinics, and then we did some work with policy. There was a referral system in which kids were referred from the primary health care into our secondary prevention program, which was an intensive 1-year program. I'm not going to talk about that today, but again, focus just on the elementary schools. So in the primary prevention intervention in targeting schools, we used CATCH, or the Coordinated Approach to Child Health, which has an evidence base. In all of our schools in Texas, they are required to do a coordinated school health program. We selected both independent school districts, Austin Independent School District and Houston Independent School District, because they were both implementing CATCH to start with, just to make sure we had a baseline that was consistent. However, it should be noted that this is an unfunded mandate. So what we did in this intervention was basically kind of a low intensity intervention where we were kind of ramping up the CATCH contacts and programs that were already in the school. So the intervention consisted of teacher training and booster sessions, our CATCH Elementary Coordination Guide, which you can see there to the corner, in the corner of the slide. And so what it does is it pretty much puts all of the program on an annualized system so that you do certain things at certain times. We also provided technical support with visits and through email, and then we did a text messaging campaign. I'm not going to talk a lot about that today. For our measures, our study design was a quasi-experimental pre- and post-test community trial. So as I said, the control did the usual CATCH program, and we did kind of a ramped up CATCH program for the intervention with more support as listed above. And then the outcomes are at baseline and after 2 years for follow-up. So the outcomes were centered around the behavioral targets. So our major outcome was BMI Z-score, but we also looked at behaviors such as fruit and vegetable intake, sugar sweetened beverage intake, physical activity, TV, sleep, and parenting. So I'm going to talk a little bit about the school intervention and then some of our process measures. So for our analysis of the school intervention, we looked at children with condition. We looked at children, but we limited our analyses to children who didn't have nutrition or physical activity limitations. We looked at 2nd and 5th grade, and then we looked at covariates. So for all of our models, we included parent education, poverty to income ratio, single parent status, child ethnicity, and child gender. So just to show you a little bit about the data at baseline and kind of what our population looked like, this compares our preschool grade 2 and grade 5th population. So the blue part of the bar represents the percent of kids who were obese. The red part is those that were overweight. And then the green part is those that were at a healthy weight. So as you can see, especially when you compare it to the NHANES data, we had a very obese population in general. We had a lot of children with obesity, especially in 2nd and 4th grade, where the prevalence was 35.2% in our area. So looking at the covariates, one of the things in our population is we had a very high poverty to income ratio, and this was because most of the parents, about 80%, had an income of $25,000 or less. We had about a third of the parents who were single parents, and then if you look at our race ethnicity, it was mostly a Latino population. We also had a significant number of African American kids in the population. So I'm going to focus on a couple of results here. And the major one, if you look at our BMI Z-score by cord catchment area. So this is looking at our intervention schools versus our comparison schools. What you see here is we had a BMI Z-score that decreased among the intervention catchment area slightly and increased in the comparison catchment area. The change was not statistically significant, although it was borderline. When we looked at the baseline to follow-up measures, though, here you can see baseline and follow-up for both comparison and intervention. We did not see any significant changes in our nutrition variables in fruit consumption, vegetable consumption, sugar-sweetened beverage consumption, and fried food consumption. And here we were looking at the number of servings. So we analyzed it a little bit differently than the previous presentation. We did find a significant effect on the number of team sports played among kids. This is 2nd and 5th grade together in the intervention group compared to the comparison group. But we did not see differences between the groups in physical activity, sleep, TV hours, video game hours, or overall quality of life. So overall, we did not see a lot of change between our comparison and intervention group. So one of the things we did as a result was we looked at the process evaluation and how much schools were implementing. During the year that we implemented the CORD project, or during the years, we had a lot of issues with getting into schools, more than we had ever had before. And so we thought that looking at the process data might shed some light on our findings. So what we did was we looked at process evaluation data after year 1 of implementation and year 2 of implementation. So as you can see there, we started in 2012, and 2013 and 2014, we collected data on implementation during the previous year. So we looked at 2 kinds of constructs in collecting these data. One were the catch constructs. So basically, did they do parts of the catch curriculum? And so we looked at the catch coordination and organizational environment, what happened in the classroom, the family outreach, the nutrition services, and then whether or not they used the catch coordination guide. Other non-catch related constructs are related to implementation of coordinated school health. And they include, did you have coordinated school health programs in the classroom? Was there communication with parents, principal support, and then other policies that were at the school level? So what we did, these were teacher surveys. We did school teacher surveys after the first year and the second year of intervention. And then we also did a total elementary school score. So that survey was usually completed. We had 1 of those per school. So the elementary school implementation was measured by that with principals or perhaps a PE teacher who completed that. So if you look at the school teacher implementation index, these were created from the school teacher questionnaires. And so the catch items consisted of 17 items, and then overall, the catch items were a subset of the overall items, which were 63 items. And so we aggregated them to represent scores at the school level. Then we did the similar thing with the overall elementary school implementation, the survey that was completed by the principal or the PE teacher for the school overall. And again, we had catch items and overall items. And you can see there were 49 items for catch and 140 for the overall. And then what we did was we standardized these from 0 to 100, the scores on both of these, and we calculated mean overall and catch aggregated implementation index scores for both the school and teachers. And so at that point, we classified the schools as high implementers. So those are the upper quartile, medium implementers, which are the middle 2 quartiles, and then low implementers, which were the lower 25%. So these data here show the difference between intervention and comparison schools, and you can see that they're arranged by year 1, year 2, and then years 1 and 2 put together. And if you look at these are the catch and overall implementation indice scores. So as you can see there were significant differences between the catch and overall implementation scores by both intervention and comparison schools for both year 1, year 2, and then year 1 and 2 together. Interestingly enough, the implementation scores were more significant during year 2 of the implementation. So this diagram represents the data in a different way. So blue represents schools that were intervention schools, and then red represents the comparison schools. And if you look at the low implementers, the medium, and then the high implementers across in these groups of 3, if you look at the first year catch in year 1, what you can see is most of the intervention schools fell within the high implementer category. More of the comparison schools landed in the low implementer, but there were also several in the medium implementer category. So if you look across it, in general, intervention schools tended to be in the high implementing group. So then we thought, what if we looked at the outcomes by implementation index? So what we did was we examined this among 2nd and 5th graders respectively, and we looked at differences by implementation level on BMI, diet, physical activity, and psychological outcomes, some of the outcomes we'd looked at before, with a mixed effects regression. We also used maximum likelihood estimation, and then we looked at interactions between implementation and time. And so when we looked at this, what we found is that in general, implementation predicted outcomes. So in this diagram, the green is the high implementers, the blue is the low implementers, and the red is the moderate implementing schools. And so as you can see, we had significant outcomes, significant differences between the low and high implementers in terms of BMI Z-score changes, which were favorable to the high implementers. And we had almost statistically significant differences between the moderate and the high implementers. Low implementers, sorry. When that was in 2nd grade, when you look at 5th grade, we saw a similar pattern, but it was statistically significant between both low and moderate implementers and high implementing schools. When we looked at the healthy eating self-efficacy by cord implementation over time for 2nd graders, we also saw significant differences between low and moderate implementers and high implementers. When we looked at fruit consumption, we did not see significant differences between moderate and high implementers, but we did see significant changes between low and high implementers. We saw a similar difference in team sports as well, with differences between low and high implementers that were statistically significant. And then finally, we did see differences between low and high implementing schools on emotional pediatric quality of life in the 5th grade. So overall, what we found with the school differences is we didn't find differences when comparing intervention versus comparison by grade level, but we did find a few significant changes when the grades were combined. So when we looked separately at 2nd and 5th grade, not much, but when they were together, we did see a few significant differences. Part of that might have been, as I mentioned at the beginning, that all the schools were doing some form of catch. But what we did find that was interesting is that the implementation level really matters. And in almost all of the variables, high implementation was related to better outcomes. So one of the things, the takeaways from this is not only do you need to do an effective program, but you really need to make sure that it's implemented fully at the school level. And there's my contact information, and thank you very much. And now we're on to Helena.
Hello, this is Helena Hoyt, and I'm excited to share the work that was done within California for the school intervention piece of the Childhood Obesity Research Demonstration Study. I am the RN-to-BS coordinator for nursing within the Imperial Valley campus of San Diego State University, and I am excited to share our work with each of 2 school districts within our community. Next. Next, Veronica. Perfect. So our partnerships and setting included the rural border region of Imperial County. So you'll notice that we have the university and our research arm, the Institute for Behavioral and Community Health. We have Clínicas de Salud del Pueblo Incorporated, which is a federally qualified health center and has regional centers within the various communities in Imperial Valley. And finally, we have the Imperial County Public Health Department. You'll note that the map shows that we're in the southern east corner of the California map, and we have about 40% children who are identified as being obese. Next. So the objectives of our project included evaluating the combined and independent effects of healthcare and public health intervention approaches to prevent and control obesity among children ages 2 to 12 living in Imperial County, California. We worked with families, a federally qualified health center, early child care and education centers, 2 different school districts, restaurants, and community recreation organizations to create a community supportive of healthy lifestyle behaviors. We targeted 4 behaviors: increasing water consumption, healthy eating, physical activity, and sleep. Next. Next, Veronica. Thank you. The public intervention that we're going to discuss today is what was done within the 2 school districts housing 13 elementary schools. So we had 4 primary strategies. The first thing was to build capacity. So the goal was to help promote physical activity using the evidence-based SPARK program. Both of the districts were already aware of SPARK and using it to a certain degree, but we really wanted to build that infrastructure. Secondly, look at physical environment changes. So we wanted to be able to go in and assess water consumption patterns and then identify methods to help install water jets and containers so that students would have access to fresh, cool water on a frequent basis. Third was we looked at the system and policy changes needed. We wanted to be able to look at what was already being done within the school wellness committee in hopes of increasing policy change. And finally, looking at communication methods. So we were able to look at using posters at each of the school sites that were consistent with what was being used in the community, and hoping that we would also increase the importance of sleep, which was not well understood when we first began this project. Next. So these are the school characteristics. You'll note that between District A and District B, there are some similarities and some distinct differences. So of note initially was the size of the district, and that is outlined in terms of students. So District A housed 758, where District B had 416 that were targeted. And then when you look at the percent of Latino Hispanic students, that was very similar in regards to free and reduced lunch use as well. So we had a largely Hispanic population that qualified for free and reduced lunch. Next. Next. So this is an outline of what was done within the school working groups and principal meetings. So you'll note on the left, there were multiple meetings held with different key informants within the school. There was more emphasis placed on promoting physical education because of the district needs and what was identified by parent and caregiver feedback. So it was sad to note that only 27% were very satisfied with promotion of physical activity in schools. There were different champions that were then addressed that we hope to build capacity through. So again, the level was, can we meet the needs of what is being said within the parent groups, within the teacher groups, and then at the administrative level. Next. Next. Next slide, please. Thank you. So we looked at SPARK being the evidence-based program that would be ideal for both of these school districts. And our goal was to increase not only the quantity, but the quality of developmentally appropriate physical activity within these elementary schools. So you'll note that we offer trainings for both of the districts. Again, District A had overall more students and teachers, however, had fewer staff that were initially trained. And then we offered money so that there could be additional PE equipment that was also purchased for the program. Next slide. So the SPARK toolkit was provided, and it was tailored to meet the specific grade levels for the teachers at within both of the districts. And then both districts also had after-school programs. So the after-school SPARK toolkit was provided. And finally, each district was given access to the SPARK website for a 3-year period. Next slide. So BMI measurement was important for us. Within the state of California, it is noted that physical fitness testing isn't required until the 5th grade. So we were excited to have local district school nurses lead the charge and involve nursing students in the RN to BS program through San Diego State University to implement a BMI measurement program. A 2-hour training was provided, and then the BMI assessments were tailored so that students did not get pulled out additionally for class. They were actually used they were pulled out just for the visual and hearing screenings that are already mandated. Kindergarten, 2nd, 3rd, and 5th grades were targeted. And then after the BMI collections, the cards were given to the caregivers, and that included the BMI for age percentile growth chart. We've noted on this slide the time that was taken to collect the measurements and how many students were measured within both districts. Next slide, please. So water access was very important for us, especially because our weather can be really warm through about October and then again in the spring. So each district installed water jets or water containers. You can see the pictures there to make it accessible for students within all 13 elementary schools. Water bottles then were also used to have a message about the Our Choice program, and this was served as a health communication channel. You'll note that we were able to provide these for everyone. However, we had limitations, and the unfortunate part was access was an issue depending on the period of the day. So lunch seemed to be the popular time to fill up those, but unfortunately the school needed to really look at adopting other approaches so that there was consistent water access throughout the entire school day. Next slide, please. Media and messaging was critical. So we used posters that also were used within the community sector, And these displayed photos of children from the target communities to promote the 4 targeted health behaviors. 8 posters were created and used within the schools to display on their walls. Tip sheets were given to the teachers, nurses, and other key educational staff with contact information. And then we also provided a sleep curriculum to help supplement the health education that was already being integrated regarding nutrition and physical activity. Next slide, please. So a mini grant program was developed as part of the project. This was specifically offered to District B as we hoped to provide additional resources that would elicit engagement. They were able to apply for up to $2,000, of which $1,500 needed to be supportive of physical education. So of the grant program, 6 of 9 applied for it and received funding. You'll see a lot of the equipment in the photo that helped to promote physical activity within District B. Next slide, please. There was already a school wellness committee within both districts. However, meetings were scheduled infrequently and not consistently. So we were able to help provide some resources and information and become a part of these wellness committees. And then you'll note the flyer that was developed on healthy lifestyle behaviors also then transitioned the efforts of CORD to the local countywide Imperial County Childhood Obesity Prevention Alliance. So fortunately, the work that was completed through California CORD has now been assumed by COPA, and members of COPA still sit on the school wellness committees, and those key behaviors are still being furthered. Next slide, please. So now I want to share some of the BMI data. So we're going to take a look at District A first. This is the prevalence of overweight and obesity by gender for years 2012, 2013, and then the follow-up year is 2013, 2014. So if you note the boys, we started off with an overall rate of 46%, and by year 2, that was reduced by 4% to 42%. Of concern was certainly the rate of obesity being at 28% and then 26% respectively. When we looked at girls, it was interesting that we actually went from an overall rate of 39% to an overall rate of 41%, with the obesity margining increasing by 2% in year 2. Next slide, please. For District B, we will look at boys versus girls again. So when we start with the year 2012, for boys in District B, we had an overall rate of 44% considered overweight and obese. You'll notice a large margin, 27% of obese, with a reduction overall to 41% by year 2. For girls, we noted that there was a decrease from 43% overall to 34%. Some of the variables happened with this decrease are that we had the local school nurse go out on leave. We were not able to measure all of the children within the 5th grade, and then also it was later in the school year than when we had measured the initial measurements the year before. Of note as well is that this would be a different student group, so certainly they wouldn't have the same characteristics. Next slide, please. So the feedback from principals was very helpful for our investigative team. Almost all the principals credited monthly presentations and materials provided by our choice staff as critical. So we found that we needed to be very visible and have a very consistent message within the schools. So as noted, our choice kept coming back. So we couldn't let it get away from us because they kept knocking on our door every month. As well, we could expect them at our meetings, giving their presentations, which I thought were important because it reminded the teachers. Next slide, please. So lessons learned from California Cord. More indoor facilities are greatly needed. We have extreme temperatures, sometimes over 120, sometimes can get very cold, so that we can promote active physical education. Additional personnel are needed, and in particular, a PE specialist really helps support one district, and you'll note that we didn't have the same level of engagement at the other district. So certainly finding those internal champions are critical. Prioritizing PE. So unfortunately, when we were looking at the multiple burdens on the school district, if you look at what the principal noted below, that actually obesity and tackling this is a low priority because there are so many competing priorities to keep these, to have children become educated and to be able to address these types of health education lessons. Secondly, we look at engaging the school wellness committee. So one of the battles that was noted is fundraising efforts. And in this community, the fast food fundraisers, the chocolates, all those food-based fundraisers seem to do well, more easily adopted. And so this would be something that needs to be tackled in future efforts. We also learned that it was critical to engage the principal. So within these communities, if you don't have the principal voluntarily stepping up to take that leadership role, you really lack an internal champion, and it's difficult to get sustaining efforts implemented. Next slide, please. So finally, I'd like to acknowledge the Center for Disease Control and Prevention for this innovative project, and then our lead investigators and staff within San Diego State, and of importance is Dr. Guadalupe Ayala, who has really led the charge. She came from the Imperial Valley and has truly been our champion in doing these population-focused efforts, and I look forward to working with this distinguished team as we continue to tackle some of these disparities. Thank you.
So thank you all very much. Thank you for the audience for listening and to the presenters. And I have a few questions for the presenters. So Helena, I thought we would maybe start with you. Among the different intervention components that you did, I was just wondering, I know y'all gave some equipment and then you also had training. Which one of those did you feel like the schools needed more or liked more? Do you have any indications of that?
Well, thank you. It was really a challenge. So originally we felt like Spark was going to be adopted easily and there was such interest. But really very quickly it became apparent that that was going to be difficult to continue. So the focus kind of shifted from that. There was such turnover within the district, so we would train folks and then they would leave. Equipment was a challenge because there would need to be a central location, and finally the weather was so rough. It was really hard to be able to consistently get the time that is required through the education code. So the water access seemed to be something that we were very interested in, and that kind of got bumped up. And then really our efforts shifted and we looked at, okay, can we at least assess to see where we are in terms of BMIs in these younger grades? Because again, in California, we only know 5th grade. So sadly, Spark did not take off as we expected, and we did have to shift our efforts.
Great, thank you. It's interesting to hear about the water consumption, I think. Dr. Frankel, I have a question for you. Could you describe the media contest a little bit more? I thought that was a really innovative part of your intervention.
Yes, and unfortunately, I was not personally involved with it, so I can't speak too specifically to it. but Shanice Chris led a publication, so I know a lot of rich details are there. But at a very high level, we asked students to submit their work, to do things like create small videos about the 5 behaviors. So we had really creative submissions from students, demonstrating how they understood the target behaviors. For example, the importance of sleep in their day-to-day lives, and conveying that message to their peers. So I think that's a really creative strategy. It gets the kids engaged, and for their peers to see that they're getting the message that way and not just from teachers or wellness coordinators, I think is really, really valuable.
Yeah, I really like the peer element of it. Just very creative.
Definitely.
So, Helena, we have a question for you from Sarah Slowa. Did you have any principals that became champions over time, or given your experience, do you see having a principal champion a prerequisite for choosing intervention schools?
Thank you, Sarah. That's a great question. So over time, we were able to see some principals become champions. So I think that is critical. We did struggle initially when we we needed to first go in with the top level administration. So district superintendents were on board, and then the next group was principals. And that year in particular, there was an influx of new principals. So they were kind of overwhelmed just by assuming the new role, and then here we showed up with these requests. But we did notice that because of the frequency in our, persistence in going through the different committees, that eventually some of the newer ones really did see a need for this. However, we did see across the board, though, that if they did not adopt early on, it was really hard to be able to then get that support on the ground level. Now, the other group, though, that was very important was getting the teachers' buy-in. And in the one district that didn't have a PE specialist, without that buy-in, it was almost impossible to be able to get this implemented within each classroom. So we typically could find a teacher who would be a champion at the grade level. But very hard if there isn't that set-aside PE specialist supported by that principal to be able to get it implemented grade-wide. I hope that answered your question, Sarah.
Yeah, I think that's real interesting that you said that some of the newer principals were more likely to serve as champions or adopt. Just an interesting observation. So, Becky, back to you. I know that it's challenging to get into schools nowadays. Did y'all encounter any challenges? And if so, how did you overcome them?
We definitely did encounter some challenges. I think, we talked about in our process evaluation more about the importance of assessing adoption readiness from both leadership and staff in the future. One of the on-the-ground challenges that we experienced was the curriculum training for teachers. I mentioned that in one community we offered those sessions during school hours, and in the other they were offered after school. And even though teachers were compensated for their time, it seemed like attending the trainings during school hours was really critical. We also had a very big challenge in that here in the Northeast, the winter when we were offering those trainings, we had several very large snowstorms that kept coinciding with the trainings. And so that was really a struggle. And we had to do some thinking on the ground in terms of offering alternatives to that 3-hour training, offering people sort of condensed version, offering them the written materials if they couldn't come in person, just, trying to be creative about getting the training materials out to them when plan A wasn't going as intended. And I think we heard a lot from teachers and other staff that the school wellness champions were really, really strong supporters and facilitators of implementation. So where we had struggles, they really helped us to overcome some of those challenges. So those are just a few things off the top of my head, but important to consider.
Yeah, I think we encountered a lot of those same challenges in terms of scheduling. One last question. Is there a chance of including gardening with the children, like the Edible Schoolyard program in New York, as an activity to do in order to increase access of and consumption of fresh vegetables? So I don't know, Helena or Becky, either one of you want to answer that?
Sure, this is Helena. So I know within our early childcare centers, there was a gardening component. Unfortunately, in the schools, that didn't come up in our interviews with principals, parents. However, some of the schools were doing that independently, but in the future, that hadn't been something that we were looking at across the entire district. So in California, it had been discussed, but that was more in the community and early childcare centers.
I know here in Austin, we had a lower intensity intervention. So we've done that with other projects, but we didn't do it with this particular project. However, I think it would be a great addition as well. All right, so we're out of time. Thank y'all for attending. We will follow up. You can go to our website and get the archive of this webinar. And we have 2 more webinars in this series. The next one will be activities in the healthcare setting for secondary prevention of childhood obesity. And then the last one will be a wrap up with overall results of the CORD project. So thanks a lot, and we hope to see you at the next couple of webinars. Bye now.